Dr. Sarah Cole. I'm an orthopaedic surgeon based in Cairns, and tonight I'm interviewing Kerry Stingel, who is an occupational therapist in Cairns. And our topic for this evening is trigger finger and Dupuytren's contracture. And we're going to talk about the differences in those two and our treatment options, and then we're going to talk about post-operative recovery and optimization. Yeah, of hand wounds. I think we should. Okay, so I feel like I'm not quite balanced. So I wanted to start with talking about trigger finger, and the reason why I wanted to talk about the two conditions at the same time is because I think there can be some confusion. They both affect the hand. The patient comes in with a stiff finger, and there's confusion about which one's which. The pathology involved in a trigger finger actually involves the flexor tendon. I'm going to use my prop inspired by Kerry. So every finger has two tendons that go to the finger. One goes to the tip, one goes to the middle phalanx, and they enable articulated flexion of the finger. The significance of that to trigger finger is that there's actually a series of bridges along the finger called pulleys that hold the finger down onto the bone. And the purpose of that is to prevent bowstringing across the finger as the finger comes into flexion. For reasons that I don't understand, you're welcome to contribute. The pulley at the base of the hand, the metacarpophalangeal joint, is prone to getting inflamed, and the tendons associated with it, the flexor digitorum superficialis and profundus, tend to get inflamed, and they tend to rub against each other. And the outcome is that the finger starts to jam, and it tends to jam in a very specific position. So the difference between a trigger finger and a Dupuytren's contracture clinically is that in the majority of cases, a trigger finger is able to intermittently get straight. So the finger will come straight, but it's not persistently stuck in flexion. In a very severe case of trigger finger, I have seen a persistently stuck trigger finger. So that's the first sign that it might, that's the first clinical sign, is that it's stuck in flexion. But in Dupuytren's, they have a distinct ridge across the palm of the hand. So there's changes in the superficial tissues of the hand that are quite distinctive when they've got a Dupuytren's contracture as opposed to a trigger finger. So the easy way is a trigger finger tends to flick in and out, but if it is stuck down, you're looking at the palm of the hand to differentiate from Dupuytren's. So they're the two conditions that we're talking about today. Dupuytren's is a different condition. It affects basically the fascia of the hand, so deep to the skin and superficial to the tendons and the nerves. The fascia of the palm becomes very thickened. We originally thought it was associated with alcohol use. That was based on a bit of a flawed study. It was a study performed in a brewery in Ireland, and the association between Dupuytren's and alcohol consumption was high, but they were paid in beer at the time. So perhaps the incidence of alcohol consumption, high rates of alcohol consumption, perhaps related to the job more so than the hand condition. So the study it's a fascinating study about causation and association and how we make those sort of judgments. But it's actually quite a lot associated with Northern Europeans, and the Northern Europeans have spread their genetic influence across Scotland, Northern England, a little bit of Ireland, and then a little bit of Northern France. So the distribution is amongst those. It's very rare amongst Polynesian populations, Asian populations, even Indian populations. It's incredibly rare. And certainly in Australia, amongst the Indigenous populations, I have seen it, but it tends to be associated with people who've had interaction with Caucasians. So it's a hereditary condition that results in the gradual onset of a flexion contracture. So the finger becomes increasingly difficult to straighten. The patient doesn't always notice that. The patient doesn't always have awareness. They tend to present with difficulty washing their face. So they notice it when they go to wash their face, that they start poking themselves in their eye, which
putting their hand
in their pocket, particularly the Scottish. They say that they can't put their hand in their pocket and reach their wallet. I like that one. It's
ironic.
I know. I was use that one. And so there's funny little things that they can't do, and it's not overwhelmingly debilitating, but they eventually start becoming concerned about it. The reason that it's difficult to state that there's, strict indications for operating, but the problem is that they start getting their fingernails tucked into the palm of their hand, and I have actually seen them really struggle with hand cleanliness. So they find it hard to clean underneath the finger, and then the nail can actually really start biting into their palm of their hand. And so so the reason why you would think about operating is you don't want to be dealing with a really tight finger down the track. I do try and ask them about when their Dupuytren started, and they really are very rare that they can tell me what the timeline is. I think the timeline can stretch anything from 1 year to 10 to 20 years. So it's very, very variable in its progression. And so there's aggressive types and there's less aggressive types. It affects 3 areas of the body. I say the hand, the sole of the foot, and it also affects the penis. I explain that I'm not a penis doctor. I'm a hand doctor, and occasionally I will look at their feet. If they have any penis problems, they can talk to their GP. But of course, it causes a contracture as well. So that's a significant problem. I do warn them. I do say, look, if you think there's something wrong, you need to present, because I would imagine that the urologist wants to see them earlier rather than late. So, so it's the same situation again. So can I start with you, Kerry? Can we start with talking about trigger finger? And I want to hear about all the things you can do for a trigger finger.
Okay. So I like to
start with education, is it?
Yeah, I like to start with the education, because finding out the history is part of the process of differentiating it from other things, but often they will have a job that requires them to be doing forceful and repetitive gripping. And particularly sometimes it's in very specific patterns. So, for example, a baker that was doing squeezing with a trigger bottle in this particular pattern and never used the long flexor. So he was completely overusing FDS. And even doing other things, his FDP had almost completely forgotten how to get used. So we had to actually train that back in, because the load that the other tendon was taking was twice what it should be. So, and we could literally palpate a distinct nodule with, when you test, say, for example, can I have your hand? See there. So if we're palpating over the level of the distal palm and crease, at that point, we leave the other fingers, we hold them in extension, and then we get the person to flex. Then we're testing FDS exclusively and out. And we should be able to feel there's some kind of bumpy there, but that it isn't necessarily a big bump and it doesn't lock. So if Mignon was having trigger finger problems, then there'd possibly be helpable nodule like the size of half a pea on the tendon, and as it goes through, it may go through under the pulley level. If we're about this level, and as the tendon goes through, lose the ability to slide through. The twist this way, will you? The little nodule pops underneath there and then can't get itself back. So it's a bit like the little pen that the thing pops out the side and you've got to push the little nodule on the bump on the side to get it back in. So I like to test, is it FDS or is it FDP? And then flex there and feel here, and can I feel the nodule? It doesn't matter hugely, thank you, except that I might change what splint I use. And that's why I would want to test one or the other, or that I might note that they really aren't doing a full fist, that they're doing just a straight fist, and therefore they might need to train. So we'll often talk about what tasks they're doing that's stirring that up to start with, and then we might just about always on the splint. And so there's different options for splinting. And I don't like the particular one that many other therapists use, because I just don't find it doesn't make any sense to me.
That's that one.
This is the one that is kind of out there, but to me it still allows way too much use. So FDS and FDP, whichever one is triggering, it's only really limiting a part of the story. So
And the principle,
it's got a bushy thing over the saw bit. So what
the principle is to restrict some movement, but not all.
Yeah, but I think it works better to go into a neoprene extension tube, and that then restricts, and this could be shorter if it is just FDS, or it could be the full length if you're not really certain which one. So it then is, you're not wanting to resist against it, so they've got to leave that finger out. So that
forces it to rest.
It forces it to rest, yeah, because it's very hard to make your finger rest. The other one I like is an overlate, and that it has to be fitted properly, and just this little plus sign on one end, and I might have actually brought the wrong size. Yeah, no, it's all right. So then if it was really just the PIP joint I wanted to restrict, then we could still encourage a little bit of DIP extension. But what you don't want is any resistance against whatever you're splinting with, because that means they're loading it further. So we don't want them loading it further, we want them resting it.
So you don't like a restrictive splint because it encourages.
Well, we are restricting, but we definitely telling them to watch what they're doing with it. So and see that they're responding. So sometimes they will take it off to do specific tasks, you know, wash their hands, go to the toilet, that kind of thing, and that's fine. So we do want them to keep moving. We don't want them to seize up. But just to not load it constantly, and that will then force a change in the tasks that they're doing.
Yes. And so so you don't mind that they have a little bit of restriction, but what you're really doing is you're trying to tell them to really not use it. You really are discouraging the use of that finger.
Yes, for a short while.
How long's a short while?
So it depends a bit on the problem and how long it's been there and what they're doing and how they are at. Probably 4 weeks would be a sign that if they're really not getting where they need to be, and they're not, you know, if it's still triggering all the time, they're probably not very excellent. In which case, if you've had them back a few times and gone over why you might need to do that, then and they're still, you know, really actively triggering, they need to see a surgeon. So often that we'll have talked before that. The doctor might have done a referral to us and to yourself, say, and so the fact that they might not get into you for a couple of weeks or months is fine. Yes, because they've got a chance to do conservative management first, and then if that hasn't worked, then that's when they'll really need that surgery. Yeah, and if it has worked, then they can just cancel their appointment. That's right. Schedule if there's ever a problem down the track. Yeah, and sometimes it really does work. I sound surprised, but I'm really not. But it is quite early. They're getting in early. They didn't want it, or they knew they had trouble last time, and it ended up. That's the other thing, is that the triggering can occur in any of the digits, whereas it is pretty common in ring finger, middle finger, I find. But as is Dupuytren. So to some extent there is that similarity. And you can have multiple going at once, but it is pretty rare. It's usually one. And in my experience, and then they may at another point go to another one. And then you'll have the odd person that's got an obvious predisposition to it. And I found one particular case, they were long-standing type 1 diabetics. And absolutely, the diabetic releases in every digit. If they come in and they say they want bilateral carpal tunnels done, and that they want this finger trigger finger release and this finger trigger, you know, if they come in with wanting 4 procedures, they're always a diabetic. And they're usually type 1 diabetics. You know, they've had significant sugar control. And I must say, I think in the last 5 or 10 years, I'm seeing less of that. And I think their sugar control is getting better. Sugar control is getting better with the new technologies and the insulin pumps and things like that. So I think I'm seeing less complication. The reason why they get it is they glycosylate their proteins. That's why they check them for glycosylated proteins. So they glycosylate their proteins. So the actual tendon is bigger. So it becomes bulkier as it passes under. So it's not just isolated when they've got a normal trigger finger. It's isolated to one little portion of the tendon, whereas the whole tendon is bigger. And so that's why they keep jamming up. And that's why they have a problem in their carpal tunnel as well. It's not just the diabetic neuropathy, it's also that the tendons are bigger in the carpal tunnel.
And that's a long, and they sort of say, oh, but my sugars have been good for the last 12 months. And I say, well, you know, because they've, with this new technology, they've got much better sugar control recently. And so they don't understand why it would have progressed if their sugar control better. Tell me, the other one I was going to say was about thumbs.
Yeah.
Tell me about success with thumbs or splints for thumbs.
Yes, so splints for thumb, we can do the same kind of thing. You just got to cut the
Shorter.
Yep, and shape it so you want it to be just fitting wherever you feel. And sometimes you'll have a definite sense of it'll be the short tendon versus the longer tendon. So yeah.
Not
and what are they doing? Well, there is FPL.
Yeah, but there's no.
Yes, FPB.
Oh, I see what you're saying.
Yep.
Oh, okay. Okay.
Yep.
Sorry, I'm thinking back to long tendon. And so, can you just tell me what you think your success rate is of treating thumbs conservatively as opposed to, say, ring or middle fingers? Bit of a trick question because I've got a theory, but I don't know if you've got a theory.
No, I've never separated them out. What's your theory?
Oh, I just find that the thumbs seem to come back after conservative treatment, wanting surgical treatment. But
I think thumbs are just demanding little lighters that need a lot. They have a lot of trouble.
Yeah,
A lot of trouble stopping use of the thumb.
Oh, interesting.
Because
Okay.
it's so important to function.
Okay,
so
I like that.
It is really
So
hard.
but I do see them. I do see once a year, I'll see someone with a locked thumb that hasn't identified that they've locked out their thumb. So when you lock out a finger, it sits like this. But when you lock out a thumb, it just sits sort of like that. And patient hasn't recognized.
You mean they locked in extension?
Yeah, they just sit there. It just sits sort of just slightly flat.
Yeah.
And it doesn't lock like that, but it's just sort of locks.
Yeah. Sometimes it's much more subtle. Yeah. But it's still very annoying. And they often, whichever digit it is, haven't worked out that because they blame the finger.
Absolutely.
Or thumb.
Yeah.
They haven't until you palpate
And then they jump.
pulley and they go, oh yeah, that is sore. Yeah. So sometimes, it's about learning to gently massage that, increase the blood flow to that area so that it knows how to, I often describe it as, if you're in the supermarket and someone has spilled a bottle of something, you go clean up on aisle 3 and they'll bring in the mop and bucket. So that's what we want the body to recognise. We've got a blood on the floor here. We need to send the body in to do its little cleanup.
Okay.
So massaging helps that. Resting can help just to stimulate that to stop revving up so much.
Very good. Okay.
Build up grips and things like that as well. So build up the grip they're using so that they're not gripping things so tightly. They're putting down their tools of trade so they're not constantly holding stuff, using different hand to do it so that they're not constantly overusing one hand. All the task modification stuff that OTs.
OTs do all the time.
Yeah.
That's good. So as far as the surgical treatment goes, I do a day surgery procedure. So I take them to the day surgery unit. I don't do it in my office. I do take them to an operating theatre. I make
someone do it in their
office. Yeah, it's common. Yes, very common. Yes, it can be an office-based procedure. I'm not comfortable with that in my practice. And I make an incision over the flexor crease. You can make a longitudinal incision. It makes it easier. The flexor crease makes it look nicer. And then I find the pulley and just basically I'm making it sound a little bit oversimplified, right? I've got to run a pair of scissors along the pulley and the pulley just pops apart as if it was under tension. The trick is to avoid all the neurovascular bundles that are running right there. The pulley pops apart and then I check if the patient's awake, because I frequently do it under local anaesthetic, because the older patients don't like having general anaesthetic, I'll ask them to demonstrate that it flows normally and they can tell me, no, it stopped clicking. And it's hard because they know not to flex it. So I say, now, can you fully flex your finger? And they're not sure about that, And they have learned to not fully flex. Yeah. And so I get them to, and when I say flex, I've got to get them to actually fully flex their distal interphalangeal joints. They're reluctant to do that, and then curl it right down to demonstrate that they can't lock it again. And then I check the release, and sometimes the tendon is actually frayed. So it's like it's been scratching against the undersurface of the pulley. And I think those people, struggle a little bit with rehabilitation because they've actually got splits in their tendon.
Mm.
So it's not actually a healthy tendon. And then I close it up with 3 stitches, take stitches out of the week. Then
we'd ideally like to see them.
yes.
Ideally before a week, because
Yeah.
then, or if they're dressed in good compression and they know to keep it on, because we really want to keep good compression
Sure.
on there to get rid of this post-op swelling, which is inevitable to have, particularly in our heat. And so people will swell more because all the vessels are more leaky in the heat. So we would often bandage with handy gauze cohesive, and that would slow them down a little bit because there's a bandage on there, not just a sticky plaster. So, you know, what would we then do? We definitely get them doing tendon gliding exercises so that they're getting that differential glide between the tendons, but not stirring it up. Getting people to take some post-op pain relief is useful, because no one wants to take their pain relief and then they end up with more problems with neuropathic pain and stuff if they're not careful. So taking that early post-op pain relief can be useful, and people are just so scared of being addicted to things, you know, and we get that, but it is useful in that early phase to know it's okay. And then definitely getting off it as soon as possible. Yeah. So managing the swelling, getting wounds healed if they're delayed healing, keeping it covered is a big part of it. And we find that people are a bit weird about keeping dressings on, take it off because it got wet. So we'll try and make sure they know how to redress it if that's been done. Sometimes they'll still be a bit. We don't usually want to splint them at that point, but sometimes if they're really sore, then we might temporarily, or we might splint them in extension if the fingers used to be flexed too much. So
that's mine. So my 2 complaints after surgery are pain in the proximal interphalangeal joint, dorsally, and swelling over the palm, just distal to the wound.
And as it heals, then we start with a lot of scar massage. So we might be doing just deep circles first. We then might introduce a bit of non-slip mat in order to get a bit more pressure and a bit more glide of the tissues. And then if they were having a bit more trouble, we might get them using a mini massager, so that I think he's missing his little knobby guy. I know, but we might get it in there. There's normally a little knobby guy here that would sit in there and massage away, just trying to stimulate that tissue to remodel if it wants to do anyway at that point. Obviously, you know, after about 2 weeks. I will sometimes get them pre or post, prior to surgery or post-op with a little ball, and it just happens to be the one I had, teaching those GIPs to work. And so a patient taught me this sort of trick. I don't know that there's any science behind it other than that it makes sense to get the DIPs to flex. So rolling a little ball down and rolling back means that the fingers have to play together. We may also use a cork to help massage scar tissue away. Then we do some strengthening once they have settled completely down, and if their strength wasn't equal. So
if the strength of each individual finger wasn't equal,
or if their grip strength on measure using a dynamometer wasn't equal.
Of the fingers or of the hands?
The whole hand.
The whole hand. Yeah, you want to work on strength.
Yep.
Yes,
if need be, but often that'll come back easily because they'll just start using it more normally.
Yes. Return to work?
Depends on what they do, as always. So if they are a butcher, that might be a bit more problematic. Then they'll need to grip a whole lot more, and there's risks if they couldn't grip well. So we determine
hard to get back.
What steps might be there, work cover may be involved if it's a work injury. If they're typing and things like that, as long as they're not full on data entry, we'd probably have them back.
You hate data entry too?
No, it's just a matter of it's more difficult to vary them.
Yeah.
But then you control it. If we're doing, say, controlling the suitable duties or recommending to the doctors what to do, then we might control that by doing part days rather than full days.
Agreed. Yes.
Yeah, or there's probably some archiving that needs to be done, some scanning that needs to be done, or
just mix it up,
not just sitting at the.
Yeah, agreed. Yeah.
No, probably we have less places up here that just do data entry, like they're not big data factories, you know. So up here you might be more mixed with doing a bit of reception,
a
or
bit of a
doing
skills
bit of
mix, aren't they?
other office stuff.
Yeah. So expect to do
Very
that.
Yeah.
We've got two waiters that are struggling to get back because they can't hold the date. They don't like that extension.
I want to bet that there was an element of
Yeah, sure.
of their long flex
Right, okay.
plates. And I think sometimes there's some reasonable performance expectations of what you're doing is just stupid, and you need to find a new way to do it.
Like what do you mean? What's an example? You mean so there's
4 plates are long enough.
just
Because you can doesn't mean you should. So this is where
they're both very hardworking.
Yeah, I get it. And I don't mean that meanly, but I kind of go,
they're very
just
hard
because
workers.
you can doesn't mean you
Yes,
should.
of course.
Yeah.
Okay.
So lighten the load, do one at a time if you have to,
I know, but they're trying to.
Workplaces maybe need to have spots where things can be brought to, then you bring them further.
Yeah,
So
that's a good suggestion. I like that one.
yeah,
So that they're not marching the entire way with the
yeah,
8 plates sort of thing.
yeah. Or you're probably not doing 8 because you've got to be able to take them off. But yeah.
That's not very
But looking
challenging.
at the, just the intricacies of what are the problems, what do they have trouble with,
Yes.
and how to problem solve around that. That's
I felt like it just the holding of the plate was the main issue, but I can now see as you're describing the way that they're holding it is.
And the other thing is, it's a hot plate.
Oh, yes, it is.
Well, you do that. That's just
Yeah, of course it is. Yeah.
But you can also see why you might not have. Like us, I remember observing at a conference venue when we were all in tables and the staff were bringing things out to this is a holding table.
Yes.
And then they would take them from there and,
Yeah.
and plate, you've got this plate, you've got that plate.
Yeah,
So they'd
sure.
be carrying one at a time, or
Yes.
one in each hand, which was much more sensible. But the room it took to have that extra table in an
Of course.
average restaurant area, you probably couldn't have it.
much more challenging. Yeah. Interesting.
Yeah.
Oh, I like that. That's the midways. Yeah.
There's
There's ways
just
around
ways.
it. Mm.
Yeah, and getting to do it rather than not being able to do it. Let's find another way. So
Yes,
you can get to do it. You might be a tiny bit slower, but you're probably not going to die.
No,
one's gonna die.
no one's
Your
going
plate's a bit.
no one's going to complain if they're a minute later.
Yeah.
That's true. Any questions about trigger finger? They're your experts.
Yeah. Like there's no particular, like from what I'm listening to, maybe not, but there's no particular, like say post-op precautions, like do's and don'ts, like absolutely wholeheartedly avoid. Why is that?
Certainly don't like them doing a lot of repetitive. No,
Yeah.
that's not true. If they choose to do a lot of repetitive gripping in the first 2 or 3 days, the wound comes apart.
Yeah.
So that to me, so having seen that to me extrapolates. If when you want to do the repetitive gripping, you feed that in down the track based on your symptomatology. So I had a patient who went back to work day 2 post-operatively and was working, digging trenches, and his wound was very, disappointing. And so
Keep the wound clean and dry and dressed.
I love clean and dry. Yeah, I love clean and dry because some of these patients are quite elderly. They find it very, because they've had a local anaesthetic, so they can have the operation, but then they have to self-manage the wound afterwards, so they can get a bit distressed. Can you just hit cancel on the don't go to sleep. That's all right. Cancel on there, and then I think on the right. If you go to the right, that one. No, that's not it. I think Facebook. Oh no, it's all right. We've got Facebook and we've got Zoom. That's okay. We're still here.
Different images.
Technology. Yeah, I know. This one's got a lag built into it.
Yes, I was moving up there in a different ratio.
Yeah, it's true. It's challenging. No, where was I up to?
Clean and dry.
Clean and dry. So I just tell them to put a Band-Aid on because the number of different things that they try and nothing, they can't get anything to stick to the palm of the hand.
It is very difficult, but it may be that the surgical dressing just needs to be bagged when they do things.
Yes.
So leave the
Provide
surgical
them.
dressing on until the wound is healed, or deliberately see your hand therapist and change it.
Yes, yes.
Things like a Mepilex light border is a perfect little dressing for that spot. And
But hand therapist is very confident with taking out stitches and changing dressings. That's part of their role. Yeah.
Training.
So you know, I can't see a physiotherapist whipping out some knee arthroscopy stitches, right? So it's a different perspective. They're specifically trained and know about wound healing rates and that's all part of their
But even just a band-aid on that, because it is so tiny.
Yes.
Unlike a Dupuytren's wound, which is a completely different story.
Yes. And they're difficult dressings for them to manage. I
Yeah.
think that's quite a bit for them to manage, and they frequently turn up with nothing.
Yeah.
Mm.
Yeah.
But anyway, that's another story. So shall we segue straight into Dupuytrens then? Because I think we've managed to talk about trigger finger for half an hour, which is pretty extraordinary. So what I wanted to say about Dupuytrens was, can I just first hear about pre-op? So, and I guess I see the world as pre-op and post-op, but in actual fact, so non-surgical treatment of Dupuytrens, what's your perspective on that?
So there's very little evidence that we can do things to stop the Dupuytren's or slow it down. Having said that, if I had a Dupuytren's contractor starting, and I don't, I possibly would put myself in Iceland. Just because there's no point in letting it deteriorate unabated. So I might deliberately just keep structure stretched, and it might be depending upon what's needing to be stretched. I might use just a neoprene tube, or I might use a hand-based lint, or I might just go, well, we'll just watch that and give it a little stretch here and there. Probably the main thing I suggest to people is that they don't use the hand as a tool, that their hand uses the tool. So it might be that if you are, say, let's pretend this is a hammer, that I don't whack the table with my hand using my hand as the tool, but I use my hand to hold the tool and do the hammering. So the beating up on the hand is not actually helpful. It tends to stimulate an inflammatory response, and that may stimulate it further.
There's a lot of commentary in the work cover space that it's not work related.
Yeah.
And so currently it is not
difficult to get approved.
Yeah, I can't get an approval for it through Work Cover Queensland. I think that will probably change over time, but it's going to be a much longer process. I personally believe that it's related to activity. I think they, as you say, they traumatize their hands and they get a low-grade inflammatory response, which becomes Dupuytren's. I think they have a genetic predisposition perhaps to the condition, but I think then also it is exacerbated by activity.
And I suppose it's difficult because it's predominantly in men, and you predominantly see it in men later in their career.
Yes,
So
it's after their careers are finished
65, 65, 70.
Yes.
Yeah. But you know, the odd woman you'll see, you know, I remember a 55-year-old woman that really wasn't doing a job that was particularly hands-on, but but she recalled uncles and grandfathers and definitely hereditary link.
Yeah, I do always ask them if they can remember, and they are struggling, but I would think that over the next 10 or 20 years, people will start remembering what grandma had.
Well, we might see there'll be a whole lot more older people living long enough to see it.
Yes,
so,
as well. And we also have a lot of, I have a lot of English orphans. So they came across in the 40s as orphans from the war, and so they don't have any family history. So they're an interesting cohort as well.
And it is funny because, you know, you sometimes they traditionally link it back to the genetic base of the Vikings, don't they?
Yes, absolutely.
Vikings, the maraudering and the pillaging and the sharing of genetic material inappropriately across the lands.
Yes.
And you don't necessarily have your family talking about that little bit of your history.
Perhaps not.
So,
Perhaps not. That's probably fair enough. So the surgical treatment for Dupuytren's is the basic premise is removing the material. So the fascia forms very thick, hard bands and nodules that attach themselves both up to the skin and then down between the tendons. It has very specific, distinctive patterns. So it almost grows like a tumor, but it's a tumor that knows where it wants to grow. So it has it's not unregulated. A tumour will naturally just grow indefinitely in any direction that the body will give it room for, whereas this actually has a path that it follows. So it's a very strange condition, and it's very difficult to explain it to patients. But one of the tricks is at this level here, just at the metacarpophalangeal joint, it tends to spiral under the nerve and then hook itself back up to the skin. And so what it actually does is it forms a white band, which looks surprisingly like a white nerve. But what it does is it starts here where you can find it. It wraps under the nerve and pushes the nerve up towards the skin. So in actual fact, coming from the top down, the first thing you see is the nerve. So the nerve is at high risk of being cut, and that's a devastating part of the procedure. So basically, I spend the whole operation starting down here and just inching the tiniest little bit of movement up the finger, and gradually sort of stretching it out as best I can, and then absolutely finding the nerve. That is the most important part of the operation. Finding the Dupuytrens is easy, it's everywhere. Finding the nerve is the main challenge, and tunneling along the nerve and making sure that you're taking out the Dupuytrens tissue.
How much does the Dupuytrens tissue look like the tendon as well? Is it very different?
It has the same colour. So because it's scar tissue, it's the same. It doesn't have a sheath over it. So a tendon has that sheath over it, so it looks slightly smoother. And the Dupuytrens looks much more like a sharper white, but it should not look like a nerve, but it's surprising at this juncture they're sort of the same diameter. I think that makes it tricky. They should be different colours, but I often can't distinguish colour. I have to do it from finding the nerve at the base and then working the way up. You can't look at it.
Done under local because you generally need to tourniquet the
Yes, I use a tourniquet. I have done it under local anaesthetic, but it's a 35-40 minute procedure, and I have had people tolerate that, which I don't understand how it works, because sometimes I can't get people to tolerate it for 10 minutes for a trigger finger, and yet I can get people to tolerate it for 40 minutes for a Dupuytrens.
And some people will tolerate splints no problem, and other people.
Well, yes, maybe that's what it is.
I suspect it's a little bit of a claustrophobic type tendency of the arms. Some people not tolerate any compression.
Oh, interesting.
Yeah, very rare to not have it.
Not tolerated at all. Yes.
They'll sometimes tell you outright.
They can't tolerate it.
No, don't put that blood pressure cuff on me either.
Yes, I have had one lady say she could not tolerate the tourniquet or the blood pressure cuff. Yeah. And I think there's a pro-inflammatory process going on there as well. And so they end up with a very long incision on the palm of their hand. On the table, I can get their finger out straight. I don't stop the operation until I can get their finger out straight. Sometimes they actually have a joint contracture. So the joint is, it cannot straighten it out, and that's because the joint has been bent for such a protracted period of time. Most people I can.
They're the ones that may also benefit from a little bit of pre-op assessment and measurement, and maybe even getting them used to what they're going to have to do, because they're definitely going to have to be splintered. But often it's just the collateral bands, collateral ligaments. That
I have released a volar plate.
And a volar plate.
I have released a volar plate to get full extension on the table. It's terrifying because you just don't know what their joint really needs. You can't assess what their joint needs, because it's just always, all the tissues have just been so tight so long. So it feels really tight when you try and release it. And then sometimes I have to do a skin flap, so they end up with a straight wound that sort of zigzags a bit, or sometimes you do a zigzag incision to try and stop that skin from contracting down. And so I sometimes do rotation flaps to take the tension off the sutures, because otherwise the wound's a lot longer to heal. And then wrap them up in a non-stick bandage. And I don't tell them to leave the bandage on, because they always bleed. So they got a lot of blood in their bandage, and I think it smells, and I think it gets moist, and then they get macerated. And I don't think that's good for their wound. So I'd like them to have their dressing changed 2 or 3 days. That's the time frame.
They see hand therapists.
And off they go to the hand therapist. Go on.
So we would take the dressing down, and sometimes that's
very early
ideally, and that does often macerate, and particularly with the heat as well, because the hand will be sweated. So we want to change that. We then will dress them in an absorbent dressing, but non-stick, and often there'll be more than one braid, one finger.
Yes, true.
It can be quite significant wounds that are pretty freaky and freak the patient out. So you got to warm them. Sometimes you got to lie them down.
Yes. Yes.
And often I'll bandage individual fingers, palm, and down a little bit. So we really want to move that fluid out because it is so invasive. The surgery that
you dismantle the whole
is
hand.
just so woolly, and we just want to get that fluid out of there so that it's not forming more scar tissue. So then we also want to splint so that we want the tissues to learn a new place rather than its resting position. And the natural resting position is flexed. So we do want it to get used to that position. So particularly for the ones that have been contracted, but we don't want to be severe with it, because if we're really severe early on, you'll end up with a flare reaction and get quite inflamed. So you might go in the past have done full-on resting splint, maybe a little straighter than this, but this is just one I had in the old box of splints. But I probably wouldn't do a full forearm component, but I might just do the hand part. But if they've been very flexed, this may be all they can handle for some of it. If it is only one finger or two fingers, I might just make this dodgy one up. I might just do a little hand-based version that has them in more extension than they would have otherwise. So then they're able to, my usual procedure would be to say, have this day and night to start with, because part of it is it's too sore to do anything, so they just don't know what to do with it. So this at least would allow the rest of the hand to be a little bit useful while using this as your work surface, if you like, maybe for holding plates on. Sorry. But then we'd view it just overnight.
So how long would you do 24/7?
If you had a 2 weeks at the most, usually, and then maybe 2 weeks with a bit on and off in the day, maybe when they're resting, but otherwise encouraging them to, even in that first 2 weeks, we would take them out and get them doing 3 or 4 times a day candlelight, so that nothing gets too seized up. But in that second 2 weeks, we then go on and off in the day, but on overnight, because it's not affecting their functional capacity having it on. It's just a good time to be straight. And then on overnight for as long as it takes for that tissue not to want to contract back down. And that could be 6 months.
Okay.
Yeah.
Yes.
But they usually feel quite comfortable in it because it feels safe.
And they know that it's not,
and they know it's not going to get hurt, and they know it's doing the right thing, and they'll eventually stop putting it on because they'll forget, and then they'll realise, well, actually, no, it's not quite straight today, so I've got to keep going.
Yes.
No, it coped okay. Left it off again the next night, and it was okay, and so it was probably time.
Wound management.
Yeah, wound management's really big. I can clearly remember this fellow that we'd started. I'd probably seen him twice post-op, and then he was on the tableland, so he rang me and said, "Yeah, it's not looking so good." And I said, "Can you send me a photo through, of the bandages?" And he says, "Yeah, it's leaking a little bit," and I'm expecting a tiny bit of strike through. There's this massive amount of ooze. I'm going, "You're coming now, right now. Get in the car. Get your wife to bring you down now." And yeah, and he had just been, it was serious fluid, so it wasn't bleeding, and he just had this massive leak, but it was a lot of wound. There was many rays involved. So yeah, it was a long time ago now, but yeah, and he was quite elderly. But yeah, this whole, it's oozing a little bit, just a little bit.
Yeah. Thank goodness for photos. Clinical photos have helped me know.
Yes, and I wasn't sure he was going to be able to do it because cameras and phones.
I know.
Big thing, and
yeah.
But yeah, so yeah, really absorbent dressings. Much cleverer than Malalin and things like that. So things like super sore P, things like that are my favorite things for this kind of thing. And the bandaging, because it's too hard to get good seal otherwise. So it has to be dressing, has to be in contact with the wound. Yes. And it should not be allowed just to dry out. Yes. Go on.
And so once the stitches are out, anything you do then?
Yeah, so these wounds will often take longer to heal. So if they take longer than 2 weeks to heal, we can expect a much more likelihood of hypertrophic scarring, so raised and thickened scarring. So it's one of my pet peeves is everyone wants to call the problem scars keloids, that unless it is truly beyond the margin of the wound, it's not a keloid, it's hypertrophic, it's raised and thickened.
Looks very different to a keloid scar.
Yeah, yeah.
Keloid scar sometimes is quite fragile and got those vascular changes.
Yeah,
Whereas this is just thick and hard, like a callus.
yeah, so they can look really good in the first couple of weeks, and you think, yes, and then you see them a couple of weeks after that, and you go, thank God I got you back, because this is nothing like what I left you with last time.
Within weeks, it can be significantly different.
And tightening down, because
the hand looks different.
The natural thing that wounds do is contract. That's what wounds do.
These wounds are different.
And these wounds are different, and I often blame certain. No, I don't. I say that rotten Dupuytren tissue gave us, you know, they had to work really carefully, but you know, I think there was a change in the surgical approach a little bit, and you know, you're used to being, if you're used to doing hands, you're used to doing delicate.
Yeah.
Whereas if you're used to banging in knees, you might say delicate. So
okay. Yeah. You think that might make a difference, the way that the procedure's done?
Yes. So the rougher they're handled, the more likely they are to be inflamed. So
more aggressive the surgery. Interesting. Okay.
Yeah.
That's good to know. Yeah.
So yeah, managing that scar tissue, and so that's the same kind of thing that we do with the trigger finger. So we want to manage the scar tissue, we want to massage it, get them handling it. We may use silicone sheeting on there.
When?
From as soon as it's healed.
Yep, good.
But
agreed.
I've probably changed over the years. I've been doing this a while, and feel that if we put silicone down too early, they don't massage as much. And
yes, okay.
the benefit of them getting in and moving layers is really much more important than making it look nice.
Okay.
So the silicone aim helps to increase the temperature internally and the moisture load internally, which helps the scar to remodel quicker. So it's good. But I think it's really important to move the layers. And that's why when we're massaging, we're doing it dry skin and moving it around. So
not cream, not vitamin E.
Cream to start with, no lotions and potions. So if I say this is like, you've got to mix the cake up first, you don't put the icing in the cake. And then you put the icing on last, so you put your cream on last.
Okay.
So moisturizer, yes, because it will need some moisturizing.
Okay.
But not massaging with the moisturizer.
Great. Okay.
And there is no magic. There's been some great hand therapy research done on what's the best cream, and there is no best cream.
Oh, okay. Right.
Yeah. I particularly hate bio oil, so that's my least favorite thing. It is.
That's a very controversial opinion.
Yeah. I just think the marketing people of bio oil have done such a fabulous job at getting that out there, but there's nothing magic about it.
Sure.
If anything, we deliberately avoid things that are really oily. So we want things to be water-based, because if we've then got them in a compression glove, anything really oily is soaking into the fibers of the glove and destroying the glove.
No, okay.
So we want water-based. So things like my favorite ones, moment Cetaphil, UV, and
so the very simple hypoallergenic moisturisers type things.
Smelly things, and
Wow. Okay.
So, but that always goes on last, and it's only a little bit, and there's often no need to do that forever. And that's the other thing that people do, is keep putting creams on forever, but what they need to do for a much longer period is the massage.
Okay.
For a long
How long?
Until it stops getting stuck.
Yep. Okay. Good.
Yep. Until the hand moves normally and doesn't have a tendency to contract.
Yeah.
So it can be months and months. Yeah. And I think, as you said, that often people will have not quite rightness about it for months. And that you can prep them for going into that, not thinking they're going to have a perfect result in 3 weeks.
I don't think they can really imagine anything different to from normal finger extension. I think it must be very difficult to look at it bent and not be and to understand that it might not be quite straight. You know, I think your brain automatically imagines it as fully normal. Go on, you got a question?
Oh, I just was saying I've got couple of
Go, yeah.
No, so my first one was, I guess to yourself, Kerry, and I've been going around in circles in my head. You mentioned about like 24/7 splinting, so
Yes.
then going to nighttime,
Yes.
because I think the comment was that's when you're not using it. I've been going around in my head about as compared to when you use it, like, because in my mind, if you're in during the day, is when you're going to be more.
Yes.
likely to
Yes.
use it.
The use of it is,
Reason, but I
the use
yeah.
is not dangerous.
Yeah.
Yeah.
What we want is just the joints to remember they can go
Okay.
straight. So unlike a tendon repair, where you've got a very fragile tendon, yes, we want that all the time, and particularly when you might be using it, but also at night, because you don't want to do the dangerous tendon movement or too forceful a grip or whatever. So that's the purpose of the splinting, is to provide prolonged extension. Yeah,
And
does
they
that
tolerate it a bit.
Yeah,
better.
that
make
does,
sense? Yeah.
Yeah.
They tolerate it a bit better at night. They'll do it for an extra month if you just make them do it at night, whereas they might give up earlier.
Yeah.
Yeah, well, because I need to go to work and I need to get ready and I need to look after the
Compliance, go on. Yeah, go on.
And the other question that I was going to ask is there, like I mentioned before about the clinical diagnosis component?
Yeah.
Is there an investigative?
For Dupotrons?
Yeah, like for comparison purposes, like.
I sometimes I can get them to report it on an ultrasound, and
Yeah.
they'll say that they can see palmar fibromatosis, so that's the alternative name. I can't usually get them to show it, to describe it on an MRI scan, because they get a bit of artifact on the surface. It's like AC joints when they say, oh, the AC joint's inflamed, and sometimes you can see it's inflamed and it's not.
Yeah.
It's just because it's so close to the surface. I think they get an artifact. So the MRI scan struggles a little bit. The ultrasound, of course, is hard, because if they've got a bent finger, they can't actually get the probe in.
Yeah.
But they do seem to have, because it's so close to the surface for both the modalities, they seem to struggle to see it. They can probably, they can probably see it clinically and then put the probe on, and then,
I don't think I've ever been in doubt as to which one it is.
Yeah.
Really.
Yeah. So why do you ask the question? Yes. Are you trying to distinguish between the two with a test?
Yeah, well, I was sort of just wondering that from the conversation before was around the clinical diagnosis component of,
Yes.
of the signs, I guess, of where you're going to the same. But I was just wondering from what would turn up the scan comparatively.
Well, they can show tendon bunching and sticking on a dynamic ultrasound. You have to specifically ask for a dynamic ultrasound. I use IMED for my dynamic hand ultrasounds because he's got a bit of hand experience. So if you ask for a dynamic ultrasound, they'll be able to show you that.
Cool.
Yeah. You could, if you sent them to IMED, they'd probably be able to give you distinguish the two diagnoses for you. But like I said before, we live and breathe hands, so we can see it as soon as the patient walks in the room.
Having said that, the report, so it's like, I went to pull up the sheet and it locked. And they're describing triggering, it's the history. And then I went like this and it was fine. Or I was able to straighten it. So sometimes the severity in my mind is, can it actively be extended, or do they have to passively release it? Or is it so sore that they have to kind of wait a bit and rub it a bit and do that? And is that happening every time they go to use their hand? Or is it only once a day? Or is it like 15 times a day? And so I'll note those things, because if that's getting better. So if I know it was only happening once a day and they've come really early for management, if it then stops happening once a day, if it's happening 15 times a day and then it still happens 3 times a day after the first week, that's still yay, but we've got more work to do. Yeah.
I think the issue, so yes, if you can get a patient to describe how it's come backwards and forwards, that's fine. But if you're in a nursing home and you've got a patient with a finger that's stuck and you've got no history from the patient, then yes, you're looking for the thickening in the palm.
It's pretty bunchy. It's not like the trigger, you won't see much else. You won't see a thing in the palm.
I do always document whether or not they've got any Dupotrons when I do a trigger finger release.
Both. Yeah.
I think they have both, because I have to release quite a bit of fascia when I do a trigger finger release. So there is
the other thing with significantly older or people in care is that it could be tone, and that in fact it'll be all fingers and it's related to their stroke or their dementia or their whatever.
That's what I've seen, like, off you, the clear day, all for.
Yeah.
this, and then even then with like full flexion, and then to the point of DIP extension from severity of the
Yeah.
flexion and DIP, yeah.
They were just so tight.
Yes,
So
so
we-
it was so tight, and then moving.
We would ideally want to splint
Yeah.
them really early and
Yeah.
not with thermoplastic.
By that point, I'm like, so far down the track.
Yeah,
It's,
This is rolled washer material, but
Mm.
making sure they're not ending up in DIP extension.
Yes.
Yes, yes, because you don't want to.
Yeah.
Any questions? Questions? You know it all?
Well, the only other thing is scar management is our spiky ball. And
Spiky ball.
yeah, I love my spiky ball. I really miss my spiky ball because I left it here one other talk. But the spiky ball, not hard spikes. There's a softness, a give to this, but it's really good for the massaging or self-massaging, and then they can roll. So it's aiding in the extension as well as the moving the tissues and everything. So yeah.
Any parting comments? We've got about 3 minutes. You to impart wisdom.
Is there anyone online that wants to comment?
You mean that might have questions? I don't
Yeah.
believe so. Can you go with the mouse and see if you can click on the Zoom window, and then you might have to sneak into the camera field. See on the top left is there's not that one, yeah. Is there any other? Can you see if you can expand out the window? Sometimes it gives you, there's in the top right hand corner it says view. In the top right hand, yeah. Sometimes that'll give you, you're on gallery. No, that's right. That means we can see everyone who's involved. So this will be recorded for posterity. Well, thank you. Thank you very much for speaking again. That was absolutely fabulous. I learned a lot. And thank you very much for coming, and thank you for asking questions. I like it when we get questions, because then we get a bit more, you get a bit more out of you, and
We know you're listening. Obviously.
oh, nice. Yeah, that's nice. And people are often very wary about hands. Physios, oh, don't do hands. We're always here to ask. Just if you've got any strange questions, like you say, send a photo. Sometimes we can, pick things over the phone. And just things that are super common for us are things that you don't see very often. And so anytime, give me a call, not a problem. And I'm sure Kerry would love to help you out as well. Yeah. All right. Thank you very much.
Thank you.